Hello, I would like to thank the organizers for the opportunity to present our work. And also I would like to thank them for placing the talk at the last day of the meeting so that you have already had a fantastic lineup of speakers that have explained the importance of microbiome in HIV infection. So I would also like to start by highlighting that Ornella Sortino from my lab has done a lot of the work that I will be presenting today. So I was asked to give the clinical perspective regarding microbiome in HIV. And I will start with my conclusions and the main points that I hope that you take away from the presentation and perhaps even from the meeting. I think there is a need for consistency in methodology and analysis, and there are very important steps being taken in that direction with large collaborations of groups and a larger sample size, which helps a lot with the analysis of microbiome. There is a great need for optimal controls in human studies that goes way beyond age and sex. And a recent study has highlighted that outside of HIV, but I think that's even more true in HIV infected studies. Associations can be convincing, but the interactions and confounders are complex, leaving intervention sometimes being the best approach to assess causality. The animal models, of course, can be very helpful to decipher causality and give some mechanistic insight, but are not definitive because, as I like to say, humans are messy and they cannot exactly follow the rules of some of the animal models where there is more homogeneity and more control of behavioral aspects and diet and genetics. And as I also like to tell my team, it's important to start with a clinical question and end with a clinical question because with a clinical intervention, because at the end of the day, this is what really matters and may affect management of people with HIV. So as we all know, there is a significant shift in morbidity and mortality in HIV infection after the introduction of effective antiretroviral therapy. Treated people with HIV have higher incidence of non-infectious, non-communicable diseases and not the usual infectious complications they had in the past. And these diseases are very strongly linked to inflammation and aging. As you can see here from the IDEA cohort, there is an increasing prevalence of people with HIV that are over the age of 70 or between 60 and 70 years old or 50 and 60. And as this age group expands, there is significant expansion of the people who have 3 or more comorbidities. And that is at a higher proportion that is seen in HIV uninfected people that you can compare here. The yellows are people with HIV infection and people without. And these are, as I mentioned, diseases that are linked to inflammation and aging. And there is significant, obviously, body of literature and work right now showing the important role of microbiome in these diseases. The pathogenesis of inflammation in HIV is multifactorial, as you have probably heard by now at this time of the meeting, and has to do with persistence of the virus, tissue damage such as lymphatic fibrosis, co-pathogens such as CMV, obesity, as well as traditional risk factors for some of these diseases that I mentioned, but of course also mucosal injury where microbiome and dysbiosis that has been described in HIV plays an important role. And all these really stimulate the immune responses and lead to persistent inflammation and higher risk for these diseases. So I'm going to start with a gut story that relates more to inflammation, and this is published data, so I'm going to go fast through that. We wanted to investigate the impact of HIV infection on the gut microbiota of people with HIV, comparing them with HIV negative matched controls that were matched for sex, sexual behavior, age, BMI, and ethnicity. And we wanted to determine what it was the impact of sexual practice on the microbial community alterations of people with HIV, mostly because there was a suggestion that perhaps MSM was what was driving the dysbiosis that was observed in HIV infection. And also we wanted to study, as others too, the potential correlations between HIV-associated microbiota shifts and inflammatory markers, as well as prevalence of age-associated diseases and comorbidities. In order to study this, we had the opportunity to collaborate with the University of Amsterdam that has a very well-characterized cohort of people with HIV and HIV seronegative controls who are all over the age of 45 and are being followed longitudinally with thorough evaluation of comorbidities that are shown here, and also with the collection of samples, including stool. From this cohort, we were able to study 80 people with HIV and 80 seronegative controls in the categories of MSM, MSW, and females, who were really almost perfectly matched for age, BMI, country of birth, and current smoking. In this group, we found that there was a clearly reduced alpha diversity in people with HIV compared to HIV-negative controls, and that was true regardless of sex or sexual practice. So it was seen in all of the different subgroups that we had the opportunity to evaluate. We also were able to compare the beta structure. You looked at beta diversity, and we found that the community variance was clearly different between people with HIV and HIV seronegative controls. And that was true again in all the three categories that we studied, the MSM, MSW, and female. We also looked at alpha diversity regardless of HIV, looking specifically at female MSM and MSW, and found that there was higher alpha diversity in MSM regardless of HIV status. And there was a very distinct clustering of MSM and MSW, suggesting that sexual practice per se was associated with variability in bacterial composition. When we looked further into that to see whether that was explaining also the differences observed in HIV in dysbiosis, we found actually that the signature that was noted in MSM, as you see here, the purple bars showing what was enriched in MSM was clearly distinct from the signature of just HIV infection that is shown in the green bars that was really completely opposite of that of MSM. And you can see also the differences here, how MSM was, the MSM status had the enrichment in erysipelothrics, as well as the Prevotella that has been described before. So showing that this is not the reason why we're seeing different signature in HIV that is not fully explained by the MSM in this population. So we found also that there was higher levels of inflammatory biomarkers, as has been described before, in this particular cohort, and it was true regardless of the subgroup. We found statistically significant higher levels of SUPAR, as well as soluble CD14, and both soluble CD14 as well as SUPAR inversely correlated with Shannon diversity. We also looked at comorbidities and found that several of the people that we studied had comorbidities. That's specifically now in the people with HIV group. And we found that the higher the dysbiosis index, the higher the number of comorbidities. So there was an association of the prevalence of comorbidities with the dysbiosis index. So in conclusion from this part, from the gut story, we did see that treated HIV infection had a robust effect on the gut bacterial community that pervaded sex and sexual practice, that the MSM microbiota signature was unique and did not overlap with that of HIV infection, that receptive anal intercourse was linked with specific gut bacterial communities, and that was the MSM Prevotella-rich enterotype, and that the dysbiosis index correlated with inflammatory markers and prevalence of non-communicable diseases. Obviously, the limitations of the study was the small sample size, that it was cross-sectional, and we did not study metabolites, which is part of our future collaboration with the University of Amsterdam to try to look longitudinally in people who ended up with clinical events, and also to look at metabolites and their effect on these observations. Now, I'm going to shift gears and discuss a little bit low CD4 counts and skin microbiome. I need to mention that there is a persistent problem of late presentation of HIV. So even in the current era, there are many places in the world, including North America, where people present for treatment of HIV with very low CD4 counts. And these patients are at particularly high risk for different skin manifestations that are very common common. And we have noticed, since we are studying people with HIV with low CD4 counts, that we very frequently refer them to dermatology. So these skin manifestations can be secondary to different viral infections that are mentioned here, fungal infections or bacterial infections, or even parasitic infections, but also malignancies, sexually transmitted diseases, drug eruptions, seborrheic dermatitis, eosinophilic folliculitis, papillopruritic eruption, which is also of a known etiology, as well as some autoimmune diseases. And really, despite extensive pathology, skin microbiome studies in HIV are very uncommon. So we had the opportunity to work at NIH with a Seger and Kong labs that study skin microbiome in people with primary immunodeficiencies. And I'm going to start with a story from a patient who had low CD4 counts, but actually did not have HIV infection, that spearheaded the collaboration with the Kong and Seger labs. So this was a patient who was 25 years old and was referred to us from Northwestern as a case of idiopathic CD4 lymphopenia. So he had relapsing nasal malignancy from HPV-16, but he also had recalcitrant skin warts that are shown here. Upon genetic evaluation, we found actually that this was not idiopathic CD4 lymphopenia, but it was a novel mutation in the IL-2 receptor gamma C, shown here, that was found in the stem cells as well as the NK cells. But actually, there was a somatic reversion in the T cells with a wild type IL-2 receptor gamma C gene that actually led to this very late presentation. So he was lucky that his sister was a full match, and he underwent a transplantation, and that led to recovery of his cell counts and also complete resolution of his skin as well as the nasal HPV manifestations. Now, evaluation of the skin microbiome of this particular patient showed that in comparison with a healthy control, where you see that viruses are really a small proportion of the skin microbiome, with alpha HPV, a small proportion of the HPV genus, he had actually a fairly large expansion of the virome with much lower bacteria. And then there was a large proportion of alpha HPV viruses. After transplantation, it looks like his skin microbiome started looking more like normal. So he had a higher now representation of bacteria, and a much lower of viruses, and a much lower proportion of alpha HPV viruses. And you can see here again the resolution of his skin warts. This is showing also the sampling that is usually done for these skin microbiome studies, and you can see also in the analysis how there is clustering of his before transplant skin areas, but there is a really intermixing of after transplantation with a healthy control, showing again this tendency to normalization after the transplantation. So looking at how does that relate to HPV-specific responses and recovery of his immune responses, we found that the T cells that, if you recall, had the wild type gene actually had really no significant changes with respect to HPV-specific responses before and after transplant. This is showing response to the virus, and this shows response to the vaccine. And you see no really significant changes before and after transplantation, in sharp contrast to the NK cell cytotoxicity that, if you recall, had the mutant, and that were really not active before transplantation. This is compared to a control. There was really no cytotoxicity, and it was completely restored after transplantation. So the conclusions also from this part is that the skin microbiome, and especially viral, may be influenced by CD4 counts. So it's definitely worth evaluating further in HIV infection. It may be altered in people with HIV, especially with low CD4 counts, and we're not sure what the effect of antiretroviral therapy is going to be. We are very interested in the role of the NK cells and the T cells in shaping the skin colonization, and that obviously requires further study in both HIV and HIV-negative participants. And then finally, as I mentioned in the beginning, interventions remain the most convincing tool of assessing causality. So I would like to end by thanking again all our collaborations, both within NIH and at the University of Amsterdam, and to thank the audience for your attention.